So the background for this pooled analysis of defined and preserved HF trials is that we know that patients with heart failure experience high burden of symptoms and physical limitations. That happens regardless of ejection fraction. And therefore, improving those outcomes, improving symptoms and physical limitations, is a very important key goal of heart failure management, again, regardless of what the ejection fraction is. With SGLT2 inhibitors, it remains unclear whether the potential benefits of these agents on symptoms, physical limitations, quality of life is consistent regardless of the ejection fraction. So in order to address that knowledge gap, we pulled data from the defined and preserved HF trials. These were our two investigator-initiated trials. Both were double-blind placebo-controlled trials of dapagliflozin or placebo in patients with either heart failure in reduced AF in defined HF or half-PAF in preserved HF. And the KCCQ or Kansas City cardiomyopathy questionnaire comprised primary endpoint in both trials. So it really created a great opportunity for us to examine the effects of dapagliflozin on symptoms and physical limitations across the entire range of ejection fraction, because we had patients with ejection fraction as low as 10% or as high as 80%. Define HF was a trial of dapagliflozin versus placebo administered for 12 weeks in patients with heart failure and reduced ejection fractions, that's 40% or less. Preserved HF was a trial of patients with heart failure and preserved ejection fraction, 45% or more, otherwise was very consistent in its design to define, which was dapagliflozin or placebo, treatment duration of 12 weeks. And again, Kansas City cardiomyopathy questionnaire, gold standard of assessing symptoms and physical limitations, comprised the primary endpoint in both trials. So what we did actually is pool the data. We did a patient-level pooled analysis. We examined the effects of dapagliflozin on KCCQ clinical summary score, which is a combination of symptoms and physical limitations. And we specifically focused on whether these effects on KCCQ clinical summary score differed in any way by ejection fraction. And we looked at ejection fraction both categorically and as a continuous variable to look at the entire range. The most important lesson, I think, from the baseline characteristics of this pooled analysis is that we had patient population that was highly symptomatic and functionally impaired. Nearly 40% of patients had NYHA class 3 or 4 symptoms. KCCQ at baseline was quite low, below 70. We also had very high proportion of women, over 40%, and about a third of the patients were Black or African American. So we had very high representation of traditionally underrepresented minorities in clinical trials. And in particular, I think, as we will talk about the results of the study, the fact that we had very symptomatic and functional impaired patient population is likely in part related to the results that we observed. For the main outcome that we examined, we saw that patients treated with dapagliflozin had a significantly greater improvement in KCCQ clinical summary score at 12 weeks compared with placebo. The treatment effect was 5 points, which is a large effect, and it was also highly statistically significant with a p-value less than 0.001. Importantly, we saw that this effect was very consistent across the range of ejection fraction. It was essentially identical, regardless of whether the ejection fraction was 40% or less, more than 40 to less than 60, or 60% and above. And when we looked at this continuously, with LVEF as a continuous variable, that treatment benefit is essentially identical across the entire range of ejection fraction. So patients with EF as low as 10% or as high as 80% benefit from dapagliflozin in terms of improvements in symptoms and physical limitations to the same extent, with absolutely no evidence of treatment effect heterogeneity. When we look at specific domains, we see very similar results. So 5-point improvement in KCCQ total symptom score, 5-point improvement in physical limitation score, nearly 4-point improvement in the overall summary score that includes all of the key domains of KCCQ. And again, when we look at the this benefit over the range of ejection fraction, there is again very consistent findings regardless of whatever the ejection fraction is. So we saw very consistent results across all of the key subgroups. That included both the ejection fraction as well as any other demographic and clinical subgroups. The other piece of the analysis I think is important is when we did the responder analysis. That's looking at proportion of patients that either get worse or get better. We saw that significantly fewer patients got worse on dapagliflozin compared with placebo, and significantly more patients got better, and specifically in the subgroup of patients that had very large improvements in symptoms and physical limitations, more than double the proportion of patients that got there on dapagliflozin than placebo. So, and again, all of those results were highly consistent by ejection fraction as well. Well, I think the take-home point here is, once again, improving symptoms and physical limitations is a key goal of management and heart failure, regardless of ejection fraction. And here we show that dapagliflozin clearly improves these measures, important measures of how patients feel and how much they're able to do within a short period of time, just 12 weeks. This benefit in a very symptomatic and functional impaired population was large. It was highly statistically significant and also clinically meaningful. So I think the bottom line is, if you have a patient with heart failure that's symptomatic and that is functionally impaired, medications like dapagliflozin, SGLT2 inhibitors, can be very beneficial, clinically beneficial, regardless of what the ejection fraction is. And I think that's really the main take-home point.